Good morning. Thank you. So I will talk about the frameworks and context at scale in the Kerala Diabetes Prevention Program. So before going to the actual session, let us see some of the selected health indicators for Kerala and India. As all of you know, I think the Kerala's health status is much ahead of the national average and far ahead of many other Indian states. For example, the infant mortality rate of Kerala is 6 compared to 28 for India, crude birth rate 13.2 compared to 19.5, life expectancy is 75 compared to 70 for India. And the most important indicator, the diabetes prevalence, is 25.5 compared to 11.4. So while all other health indicators are much better for India, for Kerala, the diabetes prevalence is more than 2 times higher than Indian average. In fact, if you take the major states of India, major states mean more than 1 crore, Kerala tops the diabetes prevalence. So you can see now, so that is why the prevention of diabetes is very, very important in the state of Kerala. So the diabetes prevention programs in Finland, USA and China have demonstrated a reduction in type 2 diabetes incidence between 42 to 58%. In the Kerala Diabetes Prevention Program, after a median follow-up of 24 months, diabetes developed in 17.1% of 507 control participants and 14.9% of 500 intervention participants, which was not significantly different. However, the incidence of diabetes in the IGT, impaired glucose tolerance subgroup, was significantly lower in the intervention group. So compared with the control group, intervention participants had a significant reduction in major cardiovascular risk factors. A significant increase in the physical functioning of functioning score of the health-related quality of life. So there were, even though the incidence was not significantly different in the intervention group, all other cardiometabolic risk was much better in the intervention group. There was a cultural adaptation of the KDPP study from, as I said, Finland, USA and other Western studies. The Kerala Diabetes Prevention Program was adapted to Kerala from evidence-based lifestyle interventions implemented in high-income countries, namely Finland, USA and Australia. Now, first of all, we did a needs assessment, then formulation of a program objectives, program adaptation and development, piloting of the program and its delivery, and program refinement and active implementation. These were the steps of the program. So this program was our randomized control trial, cluster randomized control trial, which was effective, that the effectiveness we have seen. So then we wanted to scale up this study to the rest of Kerala. So that is the objectives of the main Kerala Diabetes Prevention Program study. To develop a program delivery model for diabetes prevention and related capacity building in the Indian state of Kerala that can be further scaled up to all of India in the future, to achieve significant improvements in the behavioral risk factors. So the methodology, this was conducted in partnership with the Kudumbashree State Mission. The people from Kerala will know this is one of the largest women's organization with more than 4.2 million members spread all over Kerala. So 3 geographically and culturally distinct districts were selected. One is from the south, central and northern Kerala, approximately 3 million population reach. In each district, the plan was to train 40 KSM, Kudumbashree State Mission trainees. Each KSM trainer was expected to train 125 peer leaders of neighborhood groups. That is a structure in the Kudumbashree Mission. In each district, 5,000 peer leaders were trained, making a total of 15,000 in the state. So this is a large scale up. So these are the districts in the study. As you can see, one from the north, Kannur, one from the middle, Ernakulam, and the southern, Kollam. 3 districts were selected for the scaling up of the program. Each of the peer leader was expected to take 12 monthly sessions to the neighborhood groups over 1 year. A neighborhood groups consists of nearly 25 women Thus, we plan to reach at least 375,000 women and their family members over a period of 1 year. The materials for the sessions were adapted from the Kerala Diabetes Prevention Program, RCT, a randomized control trial, and modified and distributed by the community development chairpersons to the peer leaders. So these are the 3 districts and trainers and training structure. So finally, we had 5,000 training peer leaders trained in each district. Totally more than 15,000 people were trained. So that they will train, they will conduct sessions, 12 sessions per year, in a year, one session per month. The inauguration of the program, if you want to scale up any program, any prevention or even treatment adherence program, anything, you want the support of the government. At the time, the government, the KT Jalil was the Minister for Local Administration. The Kudumbasri comes under local administration. He inaugurated the program. As you can see, women's organization, there are 4.3 million women. So they are mostly women. We wanted to implement the scale up through the women's organization. So these were the resources distributed to the study. The training manual, flip chart, measuring tapes, training manual, flip chart, measuring tapes of peer leader training for participants. They received classes, no other, and only weighing scales and measuring tapes were given. So this was the content of the small group. As I said, there were 12 sessions. The first session was inaugural meeting about the importance of prevention of diabetes and the adaptation of lifestyle modification. Second session was on how to control diabetes. Third was on prevention of diabetes and overview. For example, focusing on weight reduction. Weight is the theme of this conference also, weight reduction. And also physical activity. Then fourth session was self-monitoring of behaviors, diet and physical activity. Fifth was identifying the components of diet behavior that require modification and goal setting for the diet. Identify, for example, how much carbohydrate you can reduce. Did you achieve your goal? Things like that. Identifying the components of physical activity. As you know, physical activity is measured in 3 domains. Work, transport, and leisure time. So in any of these domains, were you able to control or improve your physical activity? Then goal evaluation of diet, goal evaluation of physical activity, and tobacco use and alcohol consumption reduction, importance and how is it related to diabetes. Sharing of the changes made in individual lifestyle and group members, evaluation of the goal attainment, and evaluation of the program impact at individual and at the community level. We also had an evaluation of the behavioral modifications. For example, we had 1,200 participants, 400 per districts. We had 3 districts, 3 into 400. Were selected using systematic random sampling and interviewed before and after the intervention. These people were selected from the neighborhood groups. All participants from the 60 selected neighborhood groups were invited to participate. Participants unwilling to provide consent or unable to contact on 3rd consecutive visit were considered as unavailable to participate in the study. So we also had a clinical and biochemical evaluation. 24 out of the 60 randomly selected neighborhood groups were chosen for blood test and clinical measurements. At least 3 individuals per neighborhood groups were invited, 312 participants. 387 individuals participated in the baseline study and 321 participated in the post-evaluation. There was some dropout, as expected. All measurements were provided free of charge at the mobile clinics. This was funded by the World Diabetes Foundation. So there was some money, so we could provide all these tests free. And what were the measurements that we did? Demographic measures as age, sex, education, occupation, etc. And the scalability REAIM framework, reach, effectiveness, adoption, implementation, and maintenance. And behavioral measures, physical activity, modified global physical activity, JPEF was used. Tobacco use, WHO STEPS questions. Alcohol use, WHO STEPS question. Diet modified food frequency questionnaire, validated in Malayalam. Clinical measures, waist circumference and weight. and biochemical measures, fasting blood sugar, 2-hour OGTT, lipid profile, such as cholesterol, HDL, LDL, and triglycerides. So these were the outcomes that we measured. Now the scale-up or EAM framework was used. Incidence of type 2 diabetes, fasting blood sugar. As you know, the diabetes is more than or equal to 126 milligram per deciliter. 2-hour OGTT, both were used. Glycemic control, fasting blood sugar and post-load glucose. And lipid profile, total cholesterol, HDL, LDL, and triglycerides. Behavioral measures, diet, physical activity, tobacco use, and alcohol use. These were the outcomes. So after a follow-up of 12 months, we had these achievements. Now, 118 KSM trainers in 3 districts were trained. Our target was 120, but we could train only 118. But the peer leaders training, we had achieved 15,226 against a target of 15,000. And neighborhood groups, we have established 15,226 neighborhoods established in the state. Each peer leader provided training to an average of 25 people, 25 women in the neighborhood group, reaching a total of 380,000 women and their family members. These are all women, but their family members included men and children. Out of the 387 participants in the baseline, 23% had diabetes, fasting blood sugar more than equal to 126, the diagnosis. In fact, at that time, this was in 2018, 17-18, at that time the Kerala average of diabetes prevalence was 19 only, although currently it is 25. At that time it was only 19. But even at that time, 23% had diabetes in the baseline, which means Kudumbasri women, they are all below poverty line women. So below poverty line, the poorer people had a higher prevalence of diabetes. That was the finding. And 38.5% had pre-diabetes, fasting blood sugar 100 to 125 milligram per dl. So compared with the baseline evaluation, post-intervention evaluation showed a greater increase in fruit and vegetable consumption. That was one of the targets for healthy diet. Significantly improved fruits and vegetable consumption. Physical activity significantly improved. And there was a reduction in the alcohol use, body weight, waist circumference, and total cholesterol. These were all significant in the some sample of the population. So what was adapted to the new context? So emphasis on peer support through group rather than individual contacts. Group members were mostly women, and the effort was to change behavior through them. As you know, most of the kitchen is managed by women. Unless you enter the kitchen, I don't think we can make any changes in the diet pattern of anybody. So participation of women was limited. Dietary behavior can be better improved through the women in Kerala. So that was the baseline. Now, if you look at the KDPP timeline, so first of all we had the needs assessment, then we have intervention development, which was culturally adapted, then we had the implementation. For all the stages we have publications. Feasibility and adaptability of the implementation, then the effective cost effectiveness of reducing diabetes risk, and the scale up that I just talked about, scaling up to 375 people all over the state, at least in 3 districts. And now we are actually following these people, about 1,000 people after 9 years. So this is again a grant from the Global Alliance for Chronic Disease. Actually, this project was funded by the Global Alliance for Chronic Disease. So we are following these people, 1,007 people, after 9 years. And we had 85% follow-up. That is, I think, a substantial follow-up after 9 years. And we had already submitted this paper for publication. And there was significant reduction in the intervention group even after 9 years. So that is a major achievement of this program. So the key messages of this diabetes prevention program, the number 1, diabetes is one of the major NCDs in Kerala. 26% adults in Kerala have diabetes. which is an ideal condition for scale-up for the prevention. Prevention is probably the only option. One of the largest women's groups in Kerala, the Kudumbashree State Mission, and the Institution of National Importance, the Sri Chitra Tirunal Institute for Medical Sciences and Technology in Trivandrum, collaborated to implement this scale-up program. Number 3, it is important to have political support in any scale-up. So Kerala government supported this program. Number 4, used existing resources of Kerala Kudumbashree State Mission, making it cost-effective and sustainable. So I think with this I conclude my presentation. I will be happy to take any questions. Thank you very much.
Thank you so much, sir, for that elaborate presentation. Can we take few questions? So any questions from the audience?
You said after the last 4 diabetes was reduced. What was the incidence?
Yeah. Diabetes, this is a subsample of the population which I told about the scaling up of the program into 380,000 population. From that population we took a very small subsample and we had a pre-test and post-test. After the intervention of 1 year, so we had a post-evaluation and we controlled, we did not check the incidence of diabetes, but there were reduction in the alcohol consumption, tobacco consumption, and improvement in the diet and diet quality. For example, fruits and vegetable consumption increased, physical activity increased. So overall, the implementation of the program of scale-up was effective in the Kerala population. That's what I said.
Wonderful. Any more questions? Otherwise, I have one question.
Yeah.
Sir, in today's era, we're talking about monitoring a lot now. How do you see monitoring becoming more available for patients and masses when it comes to, of course, CGM may be out of scope for a lot, but how about the frequency of monitoring with self-monitoring blood glucose using glucometers?
No, sir, I was actually talking about the prevention. How do you prevent diabetes? You are talking about the controlling of all the existing diabetes. In that case, definitely monitoring is very important. So what my main point is that we have, for example, in Kerala, 25.4, almost a quarter of the adults have diabetes. Now, for example, if you take the Kerala population, we have 3 crores, 33 million population. So about two or three districts of the entire Kerala state is diabetics. Only diabetes population. How do you prevent them? That is the focus. In all this diabetes, I had attended the national conference in Mumbai also. The focus was actually prevention of diabetes. But there was only two sessions on prevention. Mostly it was control of diabetes, treatment of diabetes. My point is that we cannot achieve anything with treatment. How can you treat this many? How many 101 million diabetics in India?
Truly agree, sir. Truly agree.
But for treatment, I agree. Monitoring is very important. Self-monitoring is very important. In a Kerala state like Kerala, monitoring is much better, I would say, than other states like glucometers and which are available and affordable in state like Kerala. And it is much better. I think the monitoring is usually taken every once in 2 months. That is what the glucose monitoring they are doing, glucometers, etc. So wherever there is monitoring, control rates are much better. Adherence is much better. So that is what we see. So definitely it is, I agree with you that monitoring and controlling of adherence to medication is very important. And medication adherence is not that good. That is why the control rates, if you look at the control rates even in Kerala, it's only 15% about the population.
True.
Very, very low on the national average.
Thank you so much, sir.
So one quick question. How important, like we all know that prevention right now is the crux of the matter, and how important is it, or how can we achieve education right at the school levels? Not just for the students, but the parents and the teachers also, to achieve a better future outcome.
I agree. That is the crux. How can you address the kids? But if you look at the kids, the childhood obesity is roaring like anything. Everywhere. childhood obesity is the most important public health problem we are facing now, globally also. But if you look at the global epidemic of obesity, there are some countries where the obesity is coming down, like the Western countries. US, most of the countries except a few countries like Australia and Finland and a few countries, most of the countries, the obesity velocity is coming down. But the obesity velocity, the fastness of the obesity epidemic is increasing in low and middle income countries. That is the biggest challenge, as you are rightly saying. How do you address childhood obesity, adolescent obesity? This is directly related to incidence of diabetes. That is the biggest challenge, and it is very, very difficult unless there is a national program, national commitment. It is very difficult to address because all the children are going fast food, not only the Western fast food, even Indian fast food. This is the biggest challenge we are facing. Unless we address childhood obesity and adult obesity, it is very difficult to prevent. That is why physical activity and diet, these are the most important, crucial things to prevent diabetes. Okay?
Thank you so much, sir.
Thank you very much.